it's really important to try and choose a treatment that suits the individual patient best. And that's at the moment a large part embedded in the skill of the clinician himself. The clinician, with their experience in medications, will know which ones are more likely to cause drowsiness or weight gain or have difficulty in suppressing appetite or making perhaps the possibility of neuropsychological problems worse. The clinician with that experience can therefore avoid these treatments in patients that might be particularly prone to these side effects or adverse effects. Conversely, the clinician can sometimes use anti-seizure medicines that can ameliorate some of these conditions, and perhaps a drug that might help with weight loss or a drug that might help with seizures and also in improving mood. And sometimes resorting to these medications at an early stage can allow the tailoring of treatment that's better. At the moment, there's not much science to predicting how patients will do, and this is where the next frontier of epilepsy care and actually neurology care will certainly take effect. Our ability to decode, interrogate genetic patterns, work out which genetic patterns will predict good response to medication in terms of seizure reduction, working out which genetic patterns will predict how well tolerated a drug will be, whether that's something as in the lines of which we know already, the HLA types and carbamazepine tolerability in certain populations. But wouldn't it be great if genetics precedes, expands, and allows us to predict which drugs are going to be tolerated, which ones are not going to cause mood disorders in particular patients. Being able to tailor that on a genetic basis, that's got to be our aim. Precision medicine, this personalisation of the treatment approach has got to be our ultimate aim in the next 25, 30 years.